Welcome, everybody. I have the great pleasure of introducing Professor Seelinger. Kim Thuy Seelinger is a research associate professor at the Brown School with a co-appointment in the School of Law. She also directs the Center for Human Rights, Gender, and Migration, which has historically been housed at the Institute for Public Health. Professor Seelinger is an expert on gender-based violence and armed conflict and forced displacement, focusing on prevention and accountability for those crimes. She's conducted research or documented human rights abuses across East and West Africa, as well as in Central America, Greece, Poland, Belarus, and Ukraine. And I know that list is not complete. In 2021, Professor Seelinger was appointed Special Advisor on Sexual Violence and Conflict to the International Criminal Court in The Hague. She was then recruited to be the ICC prosecutor's first senior coordinator on gender-based violence crimes and crimes against and affecting children. Taking academic leave from WashU, Professor Seelinger has overseen the office's work in these areas and helped lead its policy development, training, curricula, and technical assistance to all trial teams. She will return to St. Louis in the summer of 2025. Over to you.
Thanks, Lindsay. It's really nice to be back. I've seen some of you in a long time. Some of you I don't know yet, but thank you for having me. I'm Kim, and I have been away for the last year and a half. So actually, it was really interesting to reacquaint myself with my own research on the plane ride over, because I've been doing other things until last Thursday. But I'm really happy to have the opportunity to think through some of the work and what it might mean for the School of Public Health, and also, of course, for other colleagues across campus. So let me try to make this work. We don't have time today, but at some point, if you're interested, I'll tell you about this painting. It's called Human Laundry. It was painted in 1945 after the liberation of the Bergen-Belsen concentration camp in Germany. It's a really fascinating story. It was painted by a Red Cross artist. And I just put it there because there's a pretty clear depiction of the relationship between health and international humanitarian law. The folks that you see being cleaned and treated are actually doctors and nurses who were pressed into service in the German military and concentration camps. But we will talk about that later if you like. For now, I'm hoping my slides. Sorry. We'll talk about the painting for 40 minutes. Nope. Right there. Okay, so this is what we'll do. This is what we'll do instead of talking about the painting for 40 minutes. A quick introduction, and maybe we'll just talk a bit of a research overview. I think there's not enough time to go into much depth about the work, but I thought maybe we would focus on one study in particular that I think is really interesting, and despite its limitations, and then just pull a couple major themes from clusters of the other work, other studies. And then I have three observations for you about the relationship between public health and international justice. And then some small examples about other ways that all of this feeds up into global policy and best practice work. And then some thoughts about next steps that might be of interest to the school. So let's see. So I think, like many of you, I'm pretty interested in violence. For me, specifically, gender-based violence that happens in context of humanitarian crisis. So whether it's armed conflict or forced displacement or political unrest. In ways it's tied to gender-based violence that happens in peacetime, but then there are elements, of course, of disruption that exacerbate risk and maybe change the forms of violence or who is perpetrating it and how they're perpetrating it and why. So I'm interested in that, but also what survivors need, what people need once they've experienced it. And if they need justice, how do we create a system of justice that doesn't hurt them in the process? Because that is very easy to do. One of the things people, we think, do seek when they have been affected by armed conflict, for example, is justice, but it may not be their primary concern. It may not be their immediate need. It may not be something they would prioritize for many years after conflict. So how do we reconcile the time frame of justice with a time frame of survivors' needs and with population recovery? And so I did become a lawyer because I'm interested in the accountability part of it. But I think immediately after law school, when I was working with survivors of armed conflict, I realized that I have just one tool, and I needed my social worker, I needed my psychologist, I needed access to the public health system and the doctors that I knew at NYU or Columbia to help out. And it's, I think, a very humbling experience for someone who's coming from law to realize you only have a very small piece of the puzzle. And if you don't work in conjunction with colleagues from other disciplines, you are not actually understanding the fullness of the justice people need. So let me just move on, I think. That's enough about me and why I'm interested in this relationship. I think it looks a little bit like this. I talked with my better half a little bit, and we couldn't make the right diagram here, but essentially there's a synergistic relationship, right, between health and justice. And if we center everything and what we're doing around human dignity, these are mutually reinforcing. And if you don't have health, it's very hard to conceive of full justice for a lot of people. And if you don't have justice, you may not have, whether it's the immigration status or the access to reparations after an international criminal trial, to get the type of medical care or psychosocial support you might need after armed conflict. So in a way, we need both. But the relationship, I think, can be clarified, and research, particularly with public health methods, can help us do that. At every level of access to justice, I think the knowledge that we get from public health research in particular is critical. So whether it's at the individual level, the survivor's actual needs, does this person need medical care? Do they need psychosocial support? Do they need other forms of support that will improve their well-being at all? This is critical to know, and I think there's a lot of research that can help illuminate the needs and priorities of survivors. But then there's the systems level approach too. Do they have access to the systems that can provide those things? And this is a little bit higher up in the individual level. Do they know what their rights are? Do they have the opportunity and the proximity to a healthcare clinic? Is the justice system accessible to them? Do they know there's someone in the police system they can trust? Is there shelter? Does the state provide shelter? Do they have to rely on local churches? What does that even look like? And then, of course, you need the legal and the policy framework. Because if you have mechanisms, but there are still inhibitions or things in the law that might prohibit or disincentivize someone from coming forward, then they can't actually, or they'll be impeded in doing that. So we do need an understanding of the way this law and policy can feed into access to justice for them. I think I wasn't quite sure how to represent this, but I was thinking about the research that we've done over time. And for me, it falls into three main buckets, and they're overlapping, of course. But as Lindsay mentioned, some of the work that we do, a smaller part of it is actual documentation of gender-based violence in humanitarian crisis settings. So that is actually the fact-finding work. How do we do that? Either in active conflict or in the wake of active conflict. And that can help with preserving a record so that can be fed into accountability processes later. But that's a smaller part of the work. Most of the studies that I've led in the last 15 years, I think, have focused on the relationship between the sectors, between the legal sector, the public health sector, and all of the things that happen at a community-based level, actually. So access to those systems is a big interest of mine. And then related to that, of course, is the extent to which we're providing survivor-centered and trauma-informed care in that work, but also in the documentation and investigation efforts that we lead. So these are a number of studies. I'll go into a few of them, but you'll see that they span a bit of time. They span different parts of the globe. They're funded by a number of different actors. Early on when I was at Berkeley, a lot of the funding came from private foundations, MacArthur, Humanity United, Oak Foundation, Soros. And then I started tapping into the United Nations agencies. UNHCR needs a lot of research done, so we worked with UNHCR quite a bit. I've had studies funded by the UK government. And then until very recently, the US State Department, the Bureau for Population, Refugees and Migration, and the Bureau for Democracy, Rights and Labor have been very generous over time. And it looks like those days are been disrupted anyway with the reorganization of the State Department this week. So this is the span of work generally, and maybe we'll just walk through a few of those studies to illustrate a few observations I have. So one observation about the relationship between public health and international justice work is that public health research can help clarify the substantive right to health and the way substantive violations of personhood implicate people's enjoyment of their right to health. And this can, in some cases, strengthen legal claims. Whether someone is applying for asylum and they're trying to show that the physical and psychological harm they would face upon return to their country amounts to persecution, or, and what I've been doing more recently, is the evidence of a war crime or a crime against humanity or an act of genocide. Like what is the health violation that is an element of a crime under international law? And if we can articulate that clearly, then that helps win a case. So either someone gets asylum or is able to stay in the country with a green card, or they might get reparation. In many of the international criminal tribunals, if you convict, in case of conviction, then victims in that case are entitled to reparation. Reparation often includes medical care, psychosocial support, access to education, other types of reparative measures. So this is where it's a bit cyclical, right? If we can articulate what the needs are and what the damage to health has been and frame it as a war crime, for example, and there's a conviction, then you get remedy. It's very hard otherwise to get population level remedy. So I thought I'd just unpack in a little bit more detail than the other studies a really interesting project we had that was requested by the British government after armed conflict had broken out in northern Ethiopia. It happened in a couple of different phases by the time we got involved. And it could be described as phase one from November 2020 to June of 2021. We don't have time, I think, to go into the full sort of ethnopolitics, what was happening in Ethiopia, but essentially we have three states up in the north of Ethiopia that were affected during this time. There's the state of Tigray in the very, very north, and the state of Afar, and then Amhara. And I'm trying to figure out how to say this in a nutshell. Essentially, the federal government of Ethiopia was choking the northern area of Tigray because there's political opposition. There was an armed group in Tigray that they feared, right? And I think you probably read the news at the time about a humanitarian blockade that was happening, trying to choke off any access to medical supplies, food, water happening in Tigray. But this was happening, and there were reports of sexual violence that the UK government was hearing, but they didn't have a way of aggregating it. And because of the development of the conflict, even early on, there was a news blackout for a good portion of the time. And so they weren't sure what was reliable. There was news media, there was local news, but a lot of the local news is owned by the state. And so they were curious about a couple specific points they wanted investigated, even if it were remotely, in order to make decisions about humanitarian relief they would fund and diplomatic efforts. So the way it's described in the news coverage also, but the UN descriptions and diplomatic channels is this first part of the conflict happened in a couple of phases. The first phase was the attacks in the north, the Ethiopian national forces and also some presence of Eritrean forces actually were active in Tigray specifically. And then in the second phase, from July to December of 2021, the Tigrayan forces actually there's what we were describing as almost echo or revenge attacks. They were moving out into Afar and Amhara and taking revenge basically on populations there. These are all different groups. And then in the third phase, there was pushback, and the Ethiopian national forces were trying to contain and really strengthen the blockade against Tigray and starve it even more of the humanitarian aid that people were needing there. The hospitals were under-resourced, and essentially broken. It had been a very developed hospital system beforehand. But these are different periods of the war up to that point when we got involved. We were asked to conduct a rapid assessment of all of the information that we could gather on conflict-related sexual violence. And they wanted to know specifically what was happening, what forms of sexual violence were happening, to whom, by whom, what we could gather about motives, and then what was the situation with access to services? What kind of services did survivors need in terms of medical care, in terms of shelter? And then were there any recommendations for immediate humanitarian diplomatic response? We didn't have a lot of time to do this. And actually we faced a number of challenges here, but we partnered with the Mukwege Foundation, which was founded by Dr. Denis Mukwege, who was a 2018 Nobel Peace Prize co-laureate. His foundation, and also a civil society group called Legal Action Worldwide, and then researchers at Mekelle University in northern Ethiopia. As it turned out, while we were developing the protocol for the study, our plan was to work with the local researchers, actually support them, and they would conduct interviews throughout the countryside and reach survivor populations, but also the folks in humanitarian service provision. But by December, they were not able to travel, actually. It was too insecure for them. And they had lost cell phone contact, and it became too dangerous for them. And so actually we had to redo our entire protocol at the very last minute and redo our IRB to look mainly at open source material, whatever we could get our hands on. And it was even risky, apparently, to conduct remote interviews with colleagues who were in the north of Ethiopia at that time. We were afraid of exposure. And so we suddenly had our key informant pool shrink considerably, actually. So it's a little bit of a strange data set, but we did what we could. And the value of at least doing this rapidly was the UK wanted, there was no analysis of just the sexual violence component across all of the scattered material. And so we could centralize it and we could analyze it with a lens for them so that they could make their funding decisions and their diplomatic decisions after. So the data looks a little bit like this. We had the 4 questions from SCDO that I mentioned. This is the Foreign Commonwealth and Development Office. We had to switch, as I said, to open source data, and that included news media, and then UN and NGO reports, and then other open source material, and then key informant interviews. And at the end of the day, we only had 7 interviews, which feels really paltry, I think. But it was really all we could get in 5 months of really trying to find people who felt safe enough to talk to us. There were some folks who were trying to talk with us, but the cell phone line kept dropping. We couldn't finish the interview. There were some folks who had made an appointment, but between the time we had set the appointment and when we could actually reach them, they would displace and crossed a border. So it was quite interesting, just from a logistical standpoint. And this is what we did with the material. We had, of course, our initial collection with our search terms, but we had to there was so much material, a lot of it was duplicated, and some of it wasn't quite on point. And so we had a couple different levels of screening and checking for both relevance and reliability. And that meant checking what the source is. Is it state controlled? Is it, like, who's funding this news source? How reliable is this NGO, for example? So we were pretty conservative, and we ended up going from about 400 pieces down to only 84 pieces once we had weeded out things that were either repetitive or we had deemed unreliable or not completely relevant. So that plus the 7 interviews, that becomes our data set for the study. I wanted to show you, it's qualitative, right? So I want to show you some quotes, and I promise you I've spared you the more graphic material. I've been looking at sexual violence and war for a really long time, and this is some of the most brutal descriptive language I've seen. So there are a couple of quotes that mention just rape, and so I'm sorry about that if that triggers anything for anybody. Please take whatever time you need. We all have emotional responses to this work, and if you need to step outside or tune me out, you absolutely want to the person. But just a few quotes maybe then about the form. So we certainly heard about rape, as I said. The quotes that I've spared you are about other forms of violence that just basically destroyed women's genital regions, or affected their pregnancies. The second quote I brought for you because we heard many accounts of children actually being targeted and suffering sexual forms of violence. In terms of perpetration, it shifted, right? Depending on the phase, you have the National Defense Forces and Eritreans being depicted as perpetrators, and then you have this echo violence as perpetrated by the Tigrayan armed groups themselves. But essentially, it was very clear that much of the motivation was the historic hostility between the groups because of different shifts in power in Ethiopia over the years and perceived need for retribution for past wrongs. So you see a lot of language that we've seen in other conflicts where there's quote unquote ethnic cleansing, or what was eventually seen and understood to be genocide. This has not been charged as such, which is another conversation, but this is definitely understood to have been motivated by ethnic animus. Maybe we'll focus more on, beyond the obvious physical health impacts to individuals, what was really striking was the complete destruction of the healthcare system in northern Ethiopia, which is a war crime in and of itself, but of course has downstream effects for people who are seeking care for the injuries that we were just discussing. And so we had mobile clinics. One of the efforts to get care into the rural areas was to use mobile clinics, but those were being attacked. Those ambulances were stolen. Every ambulances and x-ray machines were stolen. Like, all this equipment was apparently quite valuable. And medication. So simple antibiotics were just stolen from a hospital. That meant that women who needed them, because they had an infection or they were in childcare, they needed painkillers even, they just couldn't get anything. Very basic things went missing, and certainly access to safe abortion after rape was largely inaccessible. And so then you have this other situation where women who couldn't travel in the periods of time where their areas were in lockdown or blocked or had too many checkpoints, they couldn't get to healthcare. And so you have women who are carrying babies to full term and either abandoning their children or forced to become mothers for children that they did not want. And this is a legacy of violence that the state of Ethiopia is now needs to deal with. There's some other quotes. There was a preemptive demand for contraception, because women often know what the risks are when there's armed conflict at the door, and they just didn't have access to it. So this is another form of, I think, deprivation that can lead to not just physical but psychological stress for survivors. And then we heard a lot about checkpoints on the road. You couldn't get through to get to the hospital. There were also guards. The Ethiopian military would have guards at the gates of a hospital. So even if someone could make it to the hospital, they had to somehow summon the courage to explain why they were there and get past a uniformed person. This was, I think, the cause of many people turning around and leaving, actually, because they were terrified. There were a number of unmet needs, as you can see, with timely access to medical care, including emergency contraception or post-exposure prophylaxis, termination of pregnancy, and other types of OBGYN care. Psychological support was just non-existent. This was even the case in IDP and refugee camps in the area. There was just no safe space. You couldn't access the regular churches. You couldn't access places that you would normally go to seek counsel or to seek assistance. Livelihood support obviously was not being provided by anyone in this context, which can impede or increase the risk of sexual exploitation. We had some reports of sexual exploitation and abuse by humanitarian workers in the area too, which unfortunately is a reality in many of these conflicts. But in this case, it was particularly hard to address because there was no communication going on. And in fact, even the headquarters in Addis or outside of Ethiopia, they couldn't contact their own workers in the north because of cell phone blockages. And so there was just no visibility on what was happening in the north for long periods of time. Obviously, food and shelter, basic necessities were missing, communication access. There was a big call for stigma reduction, I think, because Ethiopia, I think it sounds that culturally talking about gender-based violence is taboo anyway and very difficult even in peacetime. And then when it comes to a situation like this where you might need help and you've been violated by someone who's seen by your own community as an enemy, and if you're pregnant, your child will be associated with that enemy, the stigma is of a different order, actually. And at the community level, people are trying to figure out, how do we do this? How do we ensure reintegration of this woman after she's had this experience? What do we do with the child she might bear? There's also, as we see in many other humanitarian settings, a lack of access to support for men and boys who might be affected by gender-based violence. This was reported in small detail. I feel quite sure it was happening to a greater extent than what was covered by the media. It usually is the case. But I know Lindsay's probably seen this too. When we're in humanitarian contexts, maybe there's services for women and girls if you're lucky, but there's almost nothing available for male survivors, whether they're children or adults. There's also an interesting set of survivors who were completely marginalized, and these were Eritrean refugees in Ethiopia because they don't have status. They're seen as suspect by the host country, and they can't go home because they've left home because they are either political dissidents or they've been oppressed in Eritrea. So they are completely dislocated and can't get services. And they're affected by this also because they're situated in the north. And then, as I mentioned, finally, children born of conflict-related sexual violence. Not only are they stigmatized and marginalized, but they lack identity documents when they're born. They don't have nationality necessarily. They're not acknowledged as part of the community. And so this creates, it's the next generation of harms that passes on, and is a huge issue to deal with in this end of the conflict. Just wanted to point out also that there were really heartbreaking risks reported and violations against healthcare workers themselves. Repeatedly, we heard about how the psychological state of the people who were providing services were deteriorating over time. They were also, we heard about, and it wasn't in the data, it was just in a phone call I'd had with a doctor there. He was saying that his colleagues were fainting in the operating theater because they hadn't eaten. They were trying to perform surgeries, and they hadn't eaten in days themselves, and they just couldn't think straight, and they were passing out. And then we heard one case of medical students who were themselves raped on their way home at night from the library to their dormitory because there was no security at all for them. And I just wanted to flag that because I think that's often not captured, actually, with the risks borne by service providers themselves. This study, I'm sorry, it's such a downer of a study. I realize when I'm talking through, like, this is my bread and butter, but I know it's really, I thank you for bearing with me. I think I wanted to use it because this is a really important slide for me. We did this because it was needed by the United Kingdom in order to make decisions, immediate decisions about humanitarian and diplomatic response to this. Whatever diplomatic pressure they could exert on the Ethiopian state they wanted to do, but they wanted to highlight this particular form of violence and the health impacts and unmet needs in their humanitarian response. And so this little study, as imperfect as it was, had legs, right? We had to do monthly briefings with the UK FCDO team. We, of course, gave them the research report when we were done, but then we were invited to present to them. We presented to the committee in the UK Parliament, and then we were invited to the US Senate Committee on Foreign Relations to present our findings to them also. Senator Jean Shaheen, beloved Senator Shaheen, is the one who invited us there, and Senator Cardin also. We presented to the Department of State, the Africa Bureau, the Bureau for Population, Refugees, and Migration, the Bureau for Democracy, Rights, and Labor, the Office of Global Women's Issues, and the Office of Global Criminal Justice. We presented to all of them and had subsequent follow-up and recommendations for them. And we presented to the U.S. Institute for Peace. All of these folks may not be there in a few weeks. USIP has also been closed down temporarily, but that is to say the actors who were relevant in our government wanted the findings and also incorporated it in the U.S. response. Senator Chris Coons had been our envoy to Ethiopia. He'd been going quite frequently, and so we had a call with him and his team just before one of his trips. I feel like the study was important because while we were limited to what others were reporting, it was very clear that we could highlight things besides just the rape. We could highlight the dimensions of reproductive violence that were happening, because this was incredibly important from a humanitarian provision and humanitarian support perspective. We also noticed something about food scarcity. So it was interesting how many reports of rape in people's homes were in the context of armed actors who hadn't been fed and they were hungry and they were going to homes and demanding food. And while they're hanging out in someone's house, they also decide to violate the daughter while the mother's cooking. And so in that way, it was interesting to think about how food scarcity actually can create just really dangerous opportunities for violence. And we have it as a line in the report. And then when the UN International Commission on Human Rights experts wrote their report, they picked that up. And I know they did because the woman who wrote that section for them told me that she had seen that and was thinking about it after our report. We also talked about intersectionality in that report because it wasn't just based on gender and ethnicity, but you would see these interesting patterns of association, people who were associated or assumed to be wives or widows of TPLF fighters, for example. And so some people were targeted also by imputed political opinion. And so it's a complex conflict with the sexual violence that was occurring, but we tried to highlight that as best we could based on the fixed reporting that was available. And then the other thing that was quite hopeful is civil society groups filed complaints before the African Court of Human Rights and just very recently in the national courts of Germany, which they can do by principles of universal jurisdiction. And they had questions and they were also pulling from the report among other sources. So I do feel like for a little study like this, it had legs, and I think that it's a good illustration of how even a small piece of research can highlight the individual level health needs and violations, but also the way the systematic destruction of the healthcare infrastructure has downstream effects and can be charged, right? If you provide enough illustration of how that works, then the justice system can pick that up. So the second observation, I'll just start clustering some of the studies. And the second observation is that the systems approach that public health takes, it's missing in law. We don't do it anymore. Like our research in law is very sort of some jurisprudence and legal analysis, and we don't look at how things work. I think public health does that, and it is critical because the legal system doesn't always work, or some parts of it work, some parts don't work, and we don't have a good understanding of that ourselves. So looking at that from the public health perspective is critical, particularly if we want to understand how these systems function and how accessible they are to survivors. So I'll just walk really quickly. It was a bit of a stroll down memory lane. So I was looking at studies that either had done at Berkeley or done at WashU, or one of them straddled the two. But this area, I just wanted to tell you very quickly about 3 studies. One was early on. I did this one at Berkeley. This was focused on accountability for sexual violence in conflict and post-conflict settings. And we did this study in Kenya, Sierra Leone, Liberia, and Uganda. We also did a separate piece in Eastern DRC, but it's not part of the report. And then the Safe Haven study looked at access to safe shelter in forced displacement settings. And for this one, we looked in Colombia, which is a massive IDP, internally displaced persons crisis and refugee crisis now. And then Haiti, which had, after the earthquake in 2020, the displacement crisis there. And then in Kenya, of course, which has a combination of things. It has two major refugee camps in the northeast and northwest, Dadaab and Kakuma, but then also after the political violence, post-election violence of late 2007, early 2008, a massive IDP situation in Nairobi in the Rift Valley, and then Thailand because of the border with Burma and all of the displacement and the camps there. And then the final study is looking at intimate partner violence and how it is understood in asylum adjudications in different countries in the Americas. And we looked in Chile, Peru, Mexico, and Canada. And I won't go into detail here, but let me just show you the types of research we were doing. And you can see how at the heart of it, we're looking at the systems. And I think since coming to Brown a few years ago and learning what so many colleagues were doing on system dynamics, I wish I had more training in that, because that would have been a really useful method to apply here. We were doing it just out of common sense, but I think we could have been a lot more sophisticated about it. The aims for this study were to identify the challenges and strategies related to the reporting of sexual violence in post-conflict settings in the national system, and then also the challenges and strategies related to investigating sexual violence and then the prosecution of sexual violence. So these are different systems actually in the legal system itself, the legal process, but different stages of work, and then gather relevant lessons during the recent periods of armed conflict or political violence. And in all of these studies, we interviewed folks from the healthcare sector, we interviewed law enforcement, we interviewed the judiciary, we interviewed civil society to see how it all fit together. And we don't have time here, but we had a number of diagrams that show the flow of folks who have survived these forms of violence and where they went first. Do they go to healthcare first? Do they go to their community support first? Almost never do they go to the police first. The law enforcement is never where people go, right? They need to make sure they aren't pregnant. They need STI testing. They need an abortion. And so the healthcare sector was the entry point almost always. Maybe community groups also for support and navigation. But this was a super interesting study, and it really depicted how the people fall through the cracks once they come to healthcare. How often are they effectively referred on to law enforcement if they're interested in that? And how does that work? It turns out there was no systematic connection, actually. It was just based on whether that nurse had a good friend at the police station and could call that person and then hand over. And sometimes it worked, but it wasn't, we needed a common SOP. We needed some joinder and something, maybe a joint, like a real clarity on who does what and how together. So this was a total of about 279 interviews across the 4 countries, and it was rich. And I think I'll show you some of the outputs of that in a minute. The Safe Haven study, we were trying to understand and mainly describe where people stay when they're fleeing gender-based violence in maybe a camp situation or an urban setting, because there aren't that many shelters, actually, like brick and mortar shelters. Sometimes there's one, but that's often high security and their eligibility criteria, and then you're trapped there forever. And so where else were they going to be safe if they were being beaten in their tent at home, or if they were afraid of some other form of gender-based violence in the camp? So we were trying to identify the models and see if we could describe them in a typology. And then shed light on challenges and strategies relevant to the provision of safe shelter, and then identify any critical protection gaps. And so we conducted these interviews in 4 countries. Some we had deeper reach than others, but essentially this was about 173 interviews across the 4. And then the final study, this had many aims, but essentially we were trying to figure out to what extent can people, survivors of intimate partner violence, access the asylum system? How is their claim viewed? Is it understood? Are all the aspects of intimate partner violence understood and seen as potentially rising to the level of persecution in that case? And then what are the challenges and barriers to succeeding in that case? And so this was a mixture of desk research into laws and regulations, but also interviews with service providers. So I looked across and was trying to figure out what they told us in common about systems and where healthcare systems in particular play a critical role. In almost every study, it was very clear that healthcare provision was the entry point. The last study, the asylum study, less so than the other 2, but but still played quite an important role, and that signified the importance of these legal systems engaging with healthcare facilities and making sure that they were accessible, making sure they had contact, making sure they understood how to share information about legal rights with people who came for medical and psychological services. Stigma was, of course, an issue in all of these studies, whether you're looking for legal aid or shelter or asylum support. It was also very clear that non-physical aspects of intimate partner violence and other forms of gender-based violence were not very recognized. If you were beaten and bloody, you could probably get some help and some attention, but psychological aspects of harm or things that didn't leave visible marks were often not acknowledged and paid as close attention to. And again, I think the most important takeaway is probably the lack of cross-sectoral collaboration and formal SOPs. Every ministry, every pillar of work had its own SOPs, and none of them connected to each other. Right? And this is where people fall through the cracks. And in a legal situation too, where you've done your post-rape care and your kit, for example, in Kenya, if there's no clear transfer of that across the system, you will lose your evidence and you have no chance of winning your case in the system like that. So I think that connectivity was the main takeaway from all of these studies. We grew these studies out also. So after this study, we got additional money from the MacArthur Foundation to then implement. So I'll show you the picture in a minute. So if we gathered a number of our study participants, these are nurses and doctors and investigators and lawyers and judges from the 4 countries across East and West Africa. And we brought them to Kampala in August of 2015 to present the findings and we get their feedback. What are we going to do with it? And they requested a lot of help developing tools, developing a sample of a cross-sector SOP that they could bring back. So that's what we worked on with MacArthur mainly for the next few years. And then this study became integrated into the Interagency Standing Committee guidelines. These are global guidelines for how one would integrate gender-based violence interventions in humanitarian settings. So we were thrilled about that, actually. So it's in global guidance. And it also became part of the Department of State Bureau of Population, Refugees, and Migration funding criteria and assessment of the programs that they support. So that was exciting in terms of impact there. And this study also, we presented it to the relevant actors in the Americas, and then the Mexican Asylum Office actually asked for training, and they have been integrating this into their training materials for their officers, which was surprising but heartening to see. So Mexico is actually pretty decent about intimate partner violence claims for asylum. Okay, the last observation I have, which I think is for me actually the most important one, is that, and this probably seems obvious to everyone in the room, especially if you are from the School of Social Work, actually, but that this survivor-centered and trauma-informed approach is so critical, not just for survivor safety and well-being, but for access to justice. And I think this was important because even if it became so apparent that if we have the systems and we may have the law and policy that we were just talking about in the other studies, if we don't have a survivor-centered approach to how we're engaging with individuals themselves, they have no reason to step into those systems at all, and we can do harm in the process. And it seems so obvious, but right now we're at a moment in international justice work where we accept this and want to do this as a concept, but how we operationalize this and how we do it in practice, I think is not clear to many practitioners. And so my little piece of this has been studying the phenomenon of disclosure in particular. And disclosure in this context for me is the act of a survivor sharing a past or feared experience of gender-based violence to a service provider in a humanitarian crisis context. And it's critical because if we can't enable safe disclosure, we can't open that door for further support, whether it's healthcare access or for access to justice. So these were 3 studies that we worked on, starting in Berkeley and then finishing up here. They studied we looked in Guatemala and Mexico, the pilot study, and then in Kenya, in Greece, and Mexico for the full studies funded by Department of State to understand who did people feel comfortable speaking to, and why, what motivated them, what were the barriers? Was it just language access? Was it the lack of opportunity? Was it fear? Was it lack of knowledge that they had the right to say anything and seek help? And then the third study was in the Middle East and North Africa, which was commissioned by the UN High Commissioner for Refugees, looking at barriers for disclosure in a mixed movement context. Who has a claim for international protection, who may have a legitimate claim for asylum, but they're mixed in a population that may not, it's a general migration population. Not everyone has a claim for asylum or international protection. And some people are just looking for a better life in Europe, and that's completely fine. But if you're surrounded by people like that, then the state and UNHCR may not be able to see you with your persecution claim amid all these other people. And so the UNHCR was very afraid that people traveling through North Africa and then in the Western and Central Mediterranean route were being lost. The people who had valid asylum and refugee claims were not getting assistance because they weren't visible and they weren't making themselves visible. So that was the purpose of the third study. People weren't coming forward. It's different than identification, which the agencies were doing proactively themselves through screening and questionnaires, but that's very agency focused. Disclosure focuses on the motivation and the ability of the survivor themselves to say something. How do we make that possible for those of them who want to? So this study was just exploring that, the decision-making around disclosure, the barriers faced, and what we can do to improve the chances that someone can come forward and make it safe for them. And this was conducted, about 63 interviews in total in the countries that we studied. This is Mexico, Greece, and Kenya. This study, as I mentioned, this was looking at similar barriers, but not focused on gender-based violence. This was focused on international protection needs at all. And this we did in Morocco, Tunisia, and Algeria. So this happened right as the pandemic happened. So we had to switch and move completely remote, which was a very weird way to do a multi-country study. But it was also very fruitful, and we were able to identify a number of challenges for the UNHCR in that region. Some of the issues: stigma, normalization of violence, impacts of trauma, of course, were barriers across these studies. And that was the same, actually, very similar in the Middle East and North Africa study. And it reaffirmed the universal truth that if we can't address stigma, if we can't address some of the individual level concerns that people have, the insecurity they have based on legal status or the impacts of their trauma, they will not come forward. And so the trick is, can we use that research to develop tools for service providers to ask the right questions, to set up a room properly, to be able to give people time when they need it and not rush disclosure. So I think in the research, you'll see there are a number of different individual and community level and structural and legal barriers that we identified. And from that, quickly, I know we're out of time. It also became clear that very specific profiles of survivors had specific challenges, right? Children in particular, folks that were urban refugees living outside the city, very distant, urban refugees and those who are very far from urban areas actually had very different challenges, victims of trafficking, LGBTIQ individuals, and just other folks who are generally invisible in these forced displacement settings. This became a toolkit, which has been translated into 7 languages, and this is the one we've been using most recently in Ukraine. Actually, the Ukrainian state and civil society organizations are training their investigators and their researchers and documenters using the toolkit, which was heartening to hear. And so maybe just a last word on above the studies. All of this has filtered up into global policy. I feel like I'm old enough now. I turned 50 this year, and I've come to the point in my life where I get to write really interesting things just because, I don't know, I've been around for a long time now maybe, but I wrote the UN Framework for the Prevention of Conflict-Related Sexual Violence in 2022. And to do this, I had to make sense of more than 24 UN agencies and their mandates and how they saw prevention and how they saw conflict-related sexual violence. And that meant actually trying to shoehorn a framework around an ecological model. for them, because some of them work at the individual level, some of them are looking at small arms trade. They don't speak the same language. So the only way to make it make sense for all of them was to borrow from public health, actually, and structure it this way. How do we prevent violence from happening? How do we mitigate the harms once it has happened? And how do we do that at every single level? And then every agency saw themselves and their work reflected in the prevention conversation, which was helpful. And then the last thing I would say here in terms of global policy is at the International Criminal Court, I was able to draft and then co-draft and edit our recent policies on gender-based crimes, policy on crimes affecting children, and also our policy on slavery crimes. And we are now not just adopting survivor-centered and trauma-informed approaches as a principle, a stated principle in these policies, but we're in the implementation stage. So we're developing the tools to do that as we charge these crimes. So this is a really exciting moment to be able to take the learning from other disciplines and bring it into the practice of law at the International Criminal Court. So I think what I'm hoping is at WashU, we can bring some of these disciplines together. The law school is just across the grass there, and they can learn a lot from folks in this building, actually. We need very much to understand the health consequences of the crimes that we think about. What does starvation mean? How does it affect a child differently than an adult? What are the long-term reproductive impacts of starvation, for example? If we're going to call it a war crime, do we understand it? But these are some potential projects that would be, I think, quite exciting to bring across schools. But I would leave it to you to see if that will be possible. And at the end of the day, I think if we just remind ourselves that when we're talking about armed conflict or humanitarian crisis, people have many, many needs, but ultimately they need human dignity, and understanding the connection between health and justice there, I think, gives us a greater chance of delivering that when they've had so much taken from them. So thank you. And the last slide, actually, just to show you this, this is very fun. I looked through the students who had helped us on these studies, actually, and you'll see they come from across this campus. This doesn't include the Berkeley students, right? This is just the WashU students. And you will see that they come from many corners of this campus, and we can do that. We can train them to speak a common language and produce a really holistic body of work that's useful. Okay, so thank you very much.
So I think we're pretty much at time. So we're going to have one really pithy cutting question. Somebody who wants to. I have no questions. That was great. You know, I was looking at it.
It's not pithy, I'm sorry. I had the privilege of being president of a board of health for 10 years. And it was Fort Wayne, Indiana, where I was at, and it was Northern Indiana. We were resettlement for Burmese, for people from Myanmar. And I was in the role that would have seen it. I don't think we were ever really trained on the prospect of this. We were taught about tuberculosis. We were taught about the infectious diseases that we need to look for. We had systems in place for all of that. And I don't know, and granted, I've been here since 2013. I was 2003 to 2013. Is that common? Or is that not part of the plan? I mean, explain to me how that happens. I feel like I might have missed something. It might have been derelict.
But was it a refugee resettlement program?
Yes.
I mean, most resettlement programs that I've worked with, they have a social work component. We always had a social worker with the lawyers, for example. So I don't know.
I guess what I'm saying is you mentioned in Mexico what they're doing, and we have that built into our own public health systems here. Because I don't remember getting that sort of training.
No, in the U.S., we have No, I don't think in our public health system. In the asylum offices, I guess the way we're structured, we have the Office of Refugee Resettlement that has some training on gender-based violence, right? And that is part of, we have fed into that in the past. For asylum cases in the US, it depends on the district office, actually. And they don't work with the public health system directly, but there is training on, like in San Francisco, for example, on gender-based violence. They're trained quite well, and they're trained very well on persecution claims based on sexual orientation and HIV positive status, because it's San Francisco and that's a huge feature of the caseload there. But I think it's quite disparate. The New York office I'm familiar with is quite well trained on these issues also. But I think it depends on where you are. It's quite decentralized, at least at that level.
I'm going to say thank you so much because we all know the drill and she's got something to be.